Okay, hi everybody. We'll get started in about 30 seconds. We just want to let everybody in. Okay, great. I think we'll go ahead and get started. Good afternoon, everybody. My name is Allison Foster. I'm the Executive Secretary for Delta Mega. So this is our 100-year anniversary. Delta Mega is an honorary society for public health, and it was established in 1924. So we're doing lots of things to celebrate this year, one of which is we have a webinar series where we're looking back on the last 10 decades and notable public health achievements. I'm going to share my screen just for a moment before I turn it over to our presenter today, and just show you what else is on our agenda for this webinar series. What you can see here is some of the first webinars we will have in 2024, in addition to this one. And then we will go all the way through to the fall. Okay, we will skip that because I'm having mouse problems. But I'm very happy to introduce you to our presenter today. So Debra Houry is the Chief Medical Officer and Deputy Director for the Program and Science at CDC. Most recently, Dr. Houry served as CDC's Acting Principal Deputy Director, and prior to that, she was for 7 years, the director of the National Center for Injury Prevention and Control. She also previously served as an associate professor at Houry University, and she was an emergency physician at Grady Memorial Hospital. She received her MD and MPH from Tulane and completed her residency training at Denver Health Medical Center. So a lot of great experience, and I'm so excited that she's going to be here to present to you today on the establishment of CDC in the 1940s. So thank you very much, Dr. Houry.
My pleasure, and it's great to be here. And hopefully many of y'all have taken the injury or violence courses at Rollins. Those were ones that I had started when I was there, including the certificate program. But today, delighted to be here to really celebrate the 100-year anniversary of Delta Omega and talking about public health really related to CDC. So the Centers for Disease Control and Prevention, formerly known as the Communicable Disease Center, was established actually to prevent malaria from spreading across the nation in 1946. We had a budget of $10 million then and fewer than 400 employees. And Atlanta was picked because that was where in the South there was a lot of malaria transmission. And that was really the focus initially for CDC, was really the mission to control malaria in the US. So if you haven't heard about it, there was this remarkable agreement in 1947 where CDC paid Emory University $10 for 15 acres of land in Atlanta. That still serves as CDC headquarters today. I think all of you have seen it. It's literally across the street from Rollins. And that's our main campus. We have several other campuses as well. The agency expanded its focus to include all communicable diseases in 1947 and to provide support to state health departments when requested. We look too at other insect-borne diseases and beyond communicable diseases, and so our name has changed over the years. So with that, I just want to share some key efforts and challenges through the decades that have informed our public health response today. So starting with the 1950s, that's when we saw a peak in polio infections with more than 21,000 paralytic cases in 1952. So we established the polio surveillance program in the 50s with cooperative agreements to make reporting across states and territories. And we had about 40 virus laboratories across the nation. As part of this, vaccines were introduced, and there's also the Global Polio Eradication Initiative that really helped with a lot of the global work, and it's reduced the number of cases by more than 99.9% since its launch. Today, we know that the best way to keep people safe from polio is to maintain high immunity against polio in the population through vaccination. We had that one case a couple of years ago, and that's why, again, it's important that our kids should get 4 doses of polio vaccine, that we're all up to date on our vaccines. Fast forwarding another decade to the 1960s, this is when we established our smallpox eradication program. And this was a really big step for CDC, as it provided the agency with its first formal operational involvement in international health. And the goal was to utilize vaccination teams to travel to assembly points and vaccinate everyone against smallpox and children against measles. And on average, we saw anywhere between 750 and 3,000 people were vaccinated for smallpox. And as a result of these efforts, smallpox was actually eliminated in the US in 1952. And then in 1959, the World Health Organization started a plan to rid the world of smallpox. And nearly 20 years later, the WHO declared it globally eradicated in 1980. And back in 1972, routine vaccination for this stopped in the US after it was considered eradicated. Going forward another decade, so in the late 1960s, CDC investigated an unidentified, highly infectious respiratory disease in Pontiac, Michigan. And this was later identified as Legionnaire's disease, but it was discovered really after the outbreak in 1976 among people who went to Philadelphia Convention of the American Legion, hence the name Legionnaire's disease. They all suffered from a type of pneumonia. We now see that the number of cases has continued to rise since 2000, with health departments reporting nearly 10,000 cases. This is likely underdiagnosed, though, because these numbers don't represent the true incidence. We have found that about 9 in 10 outbreaks are caused by problems preventable with more effective water management. Common sources of infection include water used for showering, cooling towers, decorative fountains, and hot tubs. Fast forward again to the 1980s, and this is when we saw the first AIDS case was reported in our Morbidity, Mortality, and Weekly Report, our MMWR publication. This is where CDC reported on 5 men with a rare lung infection in Los Angeles. The men also showed signs of severe immune suppression, and it was determined that all 5 men were gay and that the infection was sexually transmitted. By the end of that year, 337 cases were reported and 130 individuals had already died. HIV was highly stigmatized in its early days, with limited information about how the virus is transmitted, and so many stigma towards men who were gay or those who had known HIV. There were also initial reports of hospital personnel becoming infected through needle sticks and skin contamination, and so this resulted in an urgent need for new isolation strategies. And so in 1985, CDC released a strategy for isolation precautions, which became known as universal precautions. The 1990s, we saw that vaccination programs really allowed us to reduce the number of cases of many childhood diseases. There was a measles epidemic in the 1990s that resulted in thousands of cases and hundreds of deaths. And when we did an investigation of these cases, we found that more than half who had had measles had not been vaccinated against measles. So in response to this, Congress passed an act creating the Vaccine for Children program. And this is a phenomenal program that entitles children 18 and younger with no-cost vaccinations that are recommended by the Advisory Committee on Immunization Practices. This program currently protects against 19 different diseases and prevents about 472 million illnesses. It's still active today, and we work with partners, both with US government as well as external partner organizations, to make sure that we're getting those vaccines out where needed. Starting in the 2000s, we had the Emergency Operations Center, known as the EOC, and this was formed to serve as a centralized place for our public health experts to monitor and respond to emergency threats. I'm guessing many of you have toured it, and you'll see that it's got many screens to where we can track data inputs, different TV stations, and that we can all be co-located in these times of crisis. CDC has responded to more than 60 public health threats since 2003 when the EOC was started. And we will deploy experts across the agency for support as well into the field. In the 2010s, CDC served on the front lines for numerous public health emergencies and activated its EOC several times, including responding to the largest Ebola outbreak in history that affected multiple countries in West Africa, and coordinating at the national level, training teams who could do contact tracing, and certainly also providing support in the US. I know Emory had a patient. I had just left Emory and moved to the CDC at that time. We also had a public health emergency called EVALI, or the acute lung disease, in response to the e-cigarettes. And that was something the Injury Center co-led with the Chronic Center. We've also implemented several non-communicable disease activities, such as tips from former smokers, which really shows how bad smoking can be and the chronic diseases and illnesses that come from it, and have people share their stories. We also have something called a milestone tracker app that lets parents track their young children's development. And drug overdoses, we've seen really increase and become a leading cause of death, and CDC led the opioid prescribing guidelines. So as I'm sure you are all too aware, we recently activated our EOC in response to the COVID-19 pandemic. And this really allowed us to focus on understanding the transmission of disease, developing laboratory test kits, and releasing prevention guidance. So today, we talk about CDC really saving lives and protecting health. We're on the cutting edge of health security. We focus on how we can put data into action. So not just collecting the information, but then how do we work with communities to ensure that what we do is having impact, and looking at how we can fight diseases before they reach our borders, and really nurturing public health, looking at pipeline programs, training, and certainly technical assistance. I think something I didn't really realize about CDC till I came to CDC was how the majority of our funding goes out to state and local entities. About 75 to 80% of our funding goes to local and state health departments. And this really allows us to protect people 24/7. And we employ more than 14,000 employees in 54 countries. And I think one of the things that can be disheartening, but I always remind myself that that's why we do it, is, when we're successful, people don't know about it, because the best public health efforts are the ones that go unseen. So looking at, our partnership with Emory. So Emory faculty are certainly research collaborators with CDC scientists and serve on CDC-led advisory committees. On the flip side, when I was an Emory professor, I brought many CDC scientists to speak to my students as well. Former CDC leaders have joined Emory. I came from Emory. And on the flip side, certainly, like Jim Curran came from CDC and then went to Emory, where he's the longest serving dean of any school of public health. He really was the pioneer in HIV/AIDS prevention and led that work I talked about in the 80s before he became dean. Other programs include Emory has received more than $180 million in CDC research funding. They have the Emory Prevention Research Center to focus on preventing cancer and other chronic diseases. And something I was a PI on when I was at Emory was the Injury Control Research Center, which focuses on things like overdose, suicide prevention, and violence prevention. And then just this fall, Emory researchers were selected as partners of CDC's new Center for Forecasting and Outbreak Analytics. So students have so many opportunities, I'd say, to really partner with CDC. I'm working as a CDC graduate assistant through the Rollins Earn and Learn program. We currently have, I think, about 85 current students that are working at CDC through this program. Outside of these graduate assistantships, CDC also partners with Rollins student organizations such as the Student Outbreak and Response Team to host additional training and networking opportunities. And because of our partnership, the CDC continues to be the top employer for graduating students at Rollins. Between 2015 to 2023, over 300 alumni noted they were working for CDC. And in addition to these students, about 75 or 76 know they pursued an ORISE fellowship after graduation. And also many students, in addition to being full-time staff at CDC, may work with CDC through government contracting and consulting through Deloitte, Booz Allen, and other private companies. So with that, that is our brief history of CDC, starting with its formation over 75 years ago. Now, I'm happy just to take some questions. And Allison, you are on mute.
And I am on mute. I should know better. So if anybody has questions for Dr. Houry, go ahead and add them to the Q&A or the chat. I actually see a couple, so I'm just going to throw them at you in no particular order. So how about the one about the name change? So see, it's really interesting. CDC has had different names over the years that probably reflect its mission at the time. I know at one point the prevention was added to the name, and what I had heard is that there was a proposal to have another agency created, and CDC ended up taking on that role. So I'd just love to hear any of your perspectives about how CDC's name and mission has changed over time overall.
Yeah, I mean, I think when you think back to the formation, that it was really supposed to be focused, on malaria. It just shows how, as our response to public health threats evolves, so does CDC. Going from malaria to other infectious diseases, so really looking at also what are leading causes of death, like high blood pressure, cancer, drug overdoses. And oftentimes people will say, maybe, particularly during COVID, we heard it, maybe CDC should focus just on infectious disease. But I really don't think you can separate infectious and non-infectious. You look at things like Zika, where it's a disease spread by mosquitoes, but it's also sexually transmitted that results in birth defects. So you have to have all these conditions and these specialties really co-located, and our experts working together. And public health, covers so many different aspects, emergency response, laboratory, data. And so we really need to be broad so that we are nimble.
Exactly. All right. Let's see, there's a question. I think the question is, so you did mention chronic disease. What, in your opinion, so what are the biggest threats with chronic disease that we should be worried about now?
So, I think high blood pressure and diabetes still contribute so much, to morbidity and mortality. I think, we are seeing improvements when it comes to smoking, but now we're seeing, among teens, things like vaping, increasing, and other drug use. And then we still have a really, our country versus other similar countries, significant maternal mortality. And so I think that's another area to really focus on is, where do we have either continued increases or significant disparities? And I'd say those are some of the ones that come to mind for chronic disease. And we saw this in COVID too, with things like high blood pressure and diabetes. People that had, multiple medical conditions did worse. And that's why I think, again, you have to focus on people as a whole and looking at health.
Thank you. Okay, so the next one, please share your thoughts about the idea that public health perception of the CDC has suffered recently, especially as a consequence of COVID and the way some politicians attacked it. And they'd like to know your thoughts about that.
Yeah, I think it certainly was tough, because we were all working on the front lines 24/7, working really hard. And no one ever loves to hear criticism, but I'd say some of it was true. Some of it certainly wasn't. I always believe you need to continually look at what you can do better. And so we've looked at ways we can communicate more often, more clearly. So for this past year, we've even had like a blog on changes in COVID so that it's more lay friendly, more up to date, to try to communicate that. I think what was difficult about COVID-19 was this was a new pathogen. This was something, we didn't have vaccines for, we didn't have treatments for when it started. So things changed as we learned more information, and we would hear, oh, CDC is changing this or that. And we were trying to be as transparent and forthcoming as possible. But people thought changes were because we didn't know something, versus that we were adapting as we were learning more. So I think because of that, we really looked within around how can we communicate more often, more clearly, and even our data. We had a lot of issues with our data initially because we can't mandate that we get data from states and local health departments that own their own data. So it took a bit of time to even have access to that data. And what people don't realize is when the public health emergency went away, so does a lot of those reporting requirements. And so we've had to look at ways that we are able to have access to data, to have more data use agreements in place, and look at different streams. So I'd say I'm always an optimist. So it has allowed us to find ways to improve our data, to improve our communication, and to really prioritize our science as well. But certainly, when you were in the midst of it, it was difficult because it's like when I was back in the ER, you want to focus on the patient, taking care of the population. And when you're, on the front lines of public health, you're doing what you believe is right. You're trying to save lives and make a difference. And having people make it political and with misinformation doesn't help.
Right. I hope we've all learned that lesson. Okay, next question. As people continue to engage in virtual spaces through avatars, social media profiles, alternative digital identities, what are the projections for digital health to be considered going forward?
So I think there's a lot of opportunities with digital health, telehealth. We certainly saw during the pandemic, there were more telehealth interventions. I think with digital health, with personalized medicine, precision medicine, genomics, there's opportunities for that as well. And then I think as we're learning a lot more about AI, how can we use that? I used ChatGPT to look at some of our suicide messaging to see how we could be more empathetic or more lay friendly. And so looking for how we can use tools like that, I think are all important. I think it's here, it's coming. We need to embrace it and learn how to best use it, and to be aware of its limitations.
Right. Yeah, it's going to keep going, that's for sure. All right, next question. So the question is about CDC's efforts and the other agencies' efforts to better coordinate under the HHS umbrella. And the comment is there's a lot of overlap, opportunities for intersection, and your thoughts on how we holistically can do better.
Yeah, I think part of it is more clear messaging on, what we're doing and how we're collaborating. And I'd say there's really a lot less overlap than people think. I think oftentimes the public will just, much of the criticism, I'd say, not much, some of the criticism during CDC, it wasn't even stuff that was in our purview, but it was just easy to, assume CDC was responsible for all of it. But what I would say is, CDC does some research, but it's largely more applied research. We have some funding, NIH, very research heavy. And so for things like, let's say mental health, they might do long cohorts on suicide or looking at suicide treatments. We're going to look at population level data, population level interventions. And for many of these areas, there's interagency groups to where we meet regularly and talk about how we collaborate, like with SAMHSA, Substance Abuse and Mental Health Services Administration. They're very focused on services. And even for a lot of our funding announcements, we'll say you must have a letter of support from the SAMHSA grantee, in your state. Make sure that there is that synergy. Things like FDA, they're very focused on, the drug regulation around laboratories. We work very closely with them on new tests. Certainly things like AHRQ. I was one of their ex officio people today around information on patient safety. So we work with them around a lot of evidence generation. CMS, we're working much more closely with now as we're trying to identify like what are public health levers. And one example I would give is with the new RSV immunizing agent. We saw that when providers were giving it, they weren't able to bill for it because it wasn't a vaccine per se, your typical vaccine. So we worked with CMS to have them look at how they could help pay for it. So we're working closely with CMS on what are some of these public health interventions or opportunities that they can really find the financing levers for. And then certainly I would say HRSA, they have the federally qualified health centers. We do a lot of work with some of our evidence-based programs and how can we work with our grantees and clinics. So I'd say we really try to work with our sister agencies closely. Certainly, as with any family, there might be miscommunication or missed opportunities, but we try to be as thoughtful about it as we can. And our director, Dr. Cohen, loves to talk about public health being a team sport and how we really need to make sure that we are engaging all the different agencies.
Right. The 1 o'clock stop. One was mine, but I'm going to go to the one that I see right here. So CDC partners with international institutions and governments, especially as it relates to training and capacity building, as well as technical cooperation. What are the considerations for international sites, institutions, governments to work with CDC?
So we do this in a few ways. And one is we have country offices. Many of those are funded via PEPFAR funding, the President's Emergency Relief Funding around HIV. And so a lot of the work in those countries are focused on HIV per se, but during COVID pandemic, since the infrastructure was there, we were able to leverage that for vaccinations, for screening. We also have other funding around global health emergencies and global health security that has allowed us to build out those country offices. So in those 50 plus countries that we have offices in, there's those really established relationships with the local government. And so I say that's where we probably have the biggest country presence, but we know we can't have an office in every single country in the world. So we now have regional offices. I believe we're up to 6 now. And an example I saw of that was when I was traveling to South America. That was when there was the unknown, but turned out to be Legionella outbreak in Argentina. And because we had the regional office there, when the Argentinian Minister of Health asked for help, we were able to deploy people there, work with them closely, do some lab testing, things like that, and work with the country. So I would say, and then the other thing is we do provide some general funding around lab capacity, data analysis, and technical assistance to many of these countries as well. And then on the flip side, I must say, learning from other countries too. I saw some great practices around antibiotic resistance and what other countries were doing that I thought we could learn from. So I think it's just as important when we are in countries learning what they are doing too.
Oh, great. Thank you. That's a wonderful answer. So the last question I'm going to ask my own. So I'm sure it's very frustrating to see diseases that we thought we quelled, died down, even eradicated, start to pop back up. And I think a lot of it's probably because of lack of trust in vaccines. So your opinion, do you think that's getting better? And what other things can we do as the public health community to get the public to trust vaccines again?
I think continuing to talk about safety and effectiveness of the vaccines is important. I think I can't be the only person talking about safety and effectiveness of vaccines. We really need everybody to do it, particularly if you're a trusted messenger in the community. So using faith leaders, other community leaders to carry those messages is really important. And I try to talk about it. Like I was at all hands yesterday for CDC, and I talked about my daughter, where she was with her vaccine, so the pediatrician had told us. And so during the COVID pandemic, at the height of it too, when vaccines were first coming out, I was very open that I had been vaccinated when they were out for kids, that my daughter had been vaccinated. And I kept saying, I'm a mom, I'm an ER doc, I'm a scientist. Like I wouldn't be doing this if I didn't believe in it. So I think using both the science and data, but also personalizing it where you can.
Yeah, that's something all of us can do. So thank you for those thoughts. All right, so we do have a 1 o'clock end, so we're going to wrap it up. So thank you, Dr. Houry. This was absolutely fantastic. It was a really great presentation about CDC and a perspective on public health over the last several decades. And just a reminder to everybody, this is an ongoing series this year. Our next webinar is going to be on wastewater infrastructure on March 28th at 1 p.m. So we hope to see you there. Thanks very much.
Thanks all. Bye.
Bye-bye.